everyone. I'm Sam Berchuck. I'm an assistant professor in biostatistics and bioinformatics at Duke University. And I gave a talk on sequential screening for psychological distress in glaucoma clinics using an AI-assisted method. The talk was motivated by the fact that psychological distress is highly prevalent in glaucoma, with some studies showing over 40% of patients with clinically meaningful distress, including symptoms of anxiety, depression, and fears of going blind. And importantly, this distress is also associated with important outcomes in glaucoma, like worse medication adherence, worse follow-up adherence, so missed appointments, worse vision-related quality of life, and also increases in disease progression and also general healthcare costs as well. And so it's critically important to be able to identify distress, although it's not currently done, mostly because of resources and the burden and the time that it takes to screen in a busy ophthalmology clinic. So our motivation was to develop an AI framework for detecting psychological distress without adding burden to a busy clinic. And there's a long history of screening for distress in clinics going back to at least 2008, where the American Heart Association introduced their screening guidelines for depression in cardiology clinics, and they suggested that there should be a two-stage screening approach where they first screen with the 2-item PHQ, that's a patient health questionnaire, and if a patient screens positive with either of those 2 items, then they administer a full PHQ-9. But even that approach is not necessarily feasible in a busy ophthalmology clinic, and so our goal was to see if we could use available electronic health records data to actually automate that first stage of screening and only administer the actual screener itself in a small subset of high-risk patients. So we've done some previous research where we developed an AI framework using the Duke Ophthalmic Registry, which had over 40,000 patients from a general ophthalmic disease patient population. In that work, we showed that we had great ability to detect psychological distress, but their outcome was actually an EHR phenotype. And so we weren't actually predicting patient-reported distress. So in this current work that we presented, we presented results on a new prospective study of 300 patients with primary open-angle glaucoma. And in that study, we actually collected patient-reported distress. So we have a gold standard measure now. We measured distress using the patient health questionnaire, the 8-item patient health questionnaire. So a validated gold standard for depressive and distress symptoms. And so we aimed to validate our AI approach. And we demonstrated that using what's called a sequential approach, where you first use an AI model to automatically screen all patients who come into the clinic, and then you only have to administer the brief PHQ-2, for example, in that high subset that has great performance. It substantially reduces the screening burden down to about only having to manually screen about 1 in every 4. And importantly, it increases important measures of screening measures like accuracy. And over the brief screener itself, the manual screener, which the universal screener requiring 100% screening of patients, it increased the positive predictive value, which is the probability that given a test is positive that the patient actually has distress, increased nearly 33% over the manual screening as well. So we're seeing that even we're getting better performance along with the reduction in the universal screening and now only having to screen about 1 in every 4 patients. So the talk demonstrated that this using an AI-assisted framework is feasible, and we're able to actually possibly integrate distress screening into busy ophthalmology clinics, which obviously is important, will allow us to identify patients who really need behavioral care that could impact their long-term glaucoma outcomes. We know that distress impacts important outcomes. I think that the 2 most commonly cited ones for distress are medication adherence. So medication adherence and follow-up adherence, which are both critical in glaucoma since it's a chronic progressive disease and the patients need to stay up on top of their treatment. So if a clinician knows that their patient is distressed, it gives them opportunities to intervene and attempt to actually alleviate the stress. There's also some interesting research that shows acute stress can increase intraocular eye pressure itself, which is the only known modifiable risk factor in glaucoma. So it really gives the clinician another angle of attack to try to treat the patient and reduce the chance of long-term disease progression. We published a previous paper where we introduced our AI framework. Essentially, when a patient comes into the clinic, we have access to their entire history of their electronic health records. So we've got their diagnoses, procedures, medications, labs, their problem list item, their clinical notes. We've got all that data, and we're essentially using machine learning models to extract that information and use it to predict their current distress when they come into the clinic. So certainly if someone has a history of going to therapy or being on an antidepressant, for example, that's going to be a good indicator of current distress. But we know that in the model, actually, we also saw that strong predictors were other systemic factors that are associated with distress. So one of the factors that showed up frequently was having a history of headache, migraine. We also saw factors related to cancer diagnoses. So it wasn't necessarily just factors associated with previously having distress itself.